Meet John. He is a 42-year-old Native American painter who is a Christian, is married and resides in Pittsburgh. He was rushed into the ER via ambulance on account of sudden body stiffness and generalized rhythmic jerking of all four limbs as observed by his wife. The ambulance was called immediately the fitting started and the jerking has continued over the last 7 minutes. He continues to seize despite 5 milligrams of IM midazolam given by paramedics while transporting the patient to the hospital. He has a medical history of epilepsy since childhood and has been non-adherent to his anticonvulsants in the last 6 weeks. No history of surgeries in the past. He drinks alcohol occasionally but does not smoke cigarettes. On account of his condition, he takes levetiracetam and sertraline, but his wife admits he has been non-adherent to his medications and also inconsistent with his clinic visits over the past weeks. He has no known drug allergies. On arrival to the ER, his vitals read a pulse rate of 130 beats per minute, blood pressure is 153/94 millimeters of mercury, he is febrile with a temperature of 38.6 degrees centigrade, he is apneic and saturating at 91% in room air. General physical examination reveals an ill-looking middle-aged man who is cyanotic and in a generalized tonic-clonic state. There are several tongue bites and pooling of oral secretions. His pupils are dilated but reactive and corneals are present. This leads us to the topic of the day, which is the most likely diagnosis: Status Epilepticus. We'll be taking a look at what Status Epilepticus is, the types of Status Epilepticus, the various causes, the step-by-step management including drugs and the doses, important investigations to be carried out, complications to look out for, and then we conclude. Let's go. First of all, what is Status Epilepticus? According to the International League Against Epilepsy, status epilepticus is defined as continuous seizure activity lasting 5 minutes or more, or 2 or more seizures without an intervening period of neurological recovery. Now, let's take a look at the 4 known types of status epilepticus. First, we have the convulsive or generalized tonic-clonic status epilepticus. This is the most obvious form with rhythmic shaking and loss of consciousness. Next, we have the non-convulsive status epilepticus, which is characterized by subtle or no visible motor activities. It is diagnosed via an electroencephalogram, often presenting with altered mental status or confusion. Next, we have the refractory type. Status epilepticus is described as refractory when convulsions persist despite appropriate first and second line treatment, which we would discuss in detail later in this video. And finally, we have the super-refractory status epilepticus. It is a life-threatening neurological emergency defined by continuous or recurring seizures that persist for 24 hours or more after the initiation of general anesthesia, or recur upon the withdrawal of anesthetic therapy. Now, let's take a look at some causes of status epilepticus. First, we have insufficient dosage or sudden withdrawal of anticonvulsants. In patients with known epilepsy, this is one of the most common causes of status epilepticus. Anticonvulsants work by maintaining inhibitory tones such as enhancing GABA activity or blocking excitatory channels. Subtherapeutic levels or abrupt cessation remove this protection, allowing unchecked neuronal firing. This can rapidly escalate from breakthrough seizures to status epilepticus, especially in those with underlying epilepsy. Non-compliance, medication changes, or pharmacokinetic issues are frequent triggers. Another important cause of status epilepticus is a metabolic condition known as hypoglycemia. Severe low blood glucose deprives brain neurons of their primary energy source, which is glucose. This leads to energy failure, impaired membrane potential maintenance, and disrupted neurotransmitter balance. Neurons become hyperexcitable, triggering seizures that can progress to status epilepticus. It is a key metabolic cause, seen in diabetics on insulin, insulinomas, or other hypoglycemic states. Next, we have stroke. Stroke may be ischemic or hemorrhagic, and it causes acute brain injury through ischemia, hypoxia, inflammation, or direct tissue damage. This creates epileptogenic foci via excitotoxic glutamate release, edema, or cortical irritation. Acute symptomatic seizures from stroke frequently evolve into status epilepticus, particularly in older adults or those with large vessel involvement. It is a leading structural or vascular cause of new-onset status epilepticus. Thiamine deficiency is another important cause of status epilepticus. Thiamine is essential for cerebral glucose metabolism and energy production. Deficiency is seen in conditions such as alcoholism, malnutrition, or hyperemesis impairs neuronal energy pathways, leading to hyperexcitability and seizures, sometimes as part of Wernicke's encephalopathy. It lowers the seizure threshold and can directly provoke status epilepticus. Empirical thiamine is often given in SHAPE protocols, especially before or with glucose, due to its prevalence and treatability in at-risk patients. Next, we have opioid toxicity. Opioids such as meperidine and propoxyphene can lower the seizure threshold via direct effects on receptors, metabolite accumulation, or secondary hypoxia from respiratory depression. It is more noted in overdose, children, patients with renal impairment, or with specific opioids such as those mentioned above. Next, we have isoniazid toxicity. Isoniazid plays a key role in the treatment of pulmonary tuberculosis. It can interfere with pyridoxine, vitamin B6, metabolism, a cofactor for glutamic acid decarboxylase in GABA synthesis. Reduced GABA, which is the main inhibitory neurotransmitter, causes profound neuronal hyperexcitability, leading to recurrent seizures and often refractory status epilepticus, accompanied by metabolic, lactic, acidosis. This is a classic toxicologic cause, and seizures respond specifically to high-dose pyridoxine administration. Finally, we have eclampsia in pregnancy. Eclampsia involves new-onset seizures, which can become status epilepticus, in the setting of preeclampsia. Mechanisms include cerebral autoregulatory failure due to severe hypertension, blood-brain barrier disruption, vasogenic or cytotoxic edema, ischemia, or microhemorrhages. Now, let's take a look at the step-by-step management of status epilepticus. Our first and most important step would be the ABCs of resuscitation. It is important to secure the airways by suction to remove secretions plugging it up. The airways can also be secured by intubation, of which the appropriate induction agent would be propofol, as it provides double benefit of sedation and seizure suppression. Ensure the patient is breathing, and this can be maintained via mechanical ventilation. Ensure to establish intravenous access early, ideally 2 large-bore cannulas, for medications, fluids, and labs. Monitor blood pressure, heart rate, and cardiac rhythm. Having secured airways, breathing, and circulation, the next step would be to reverse any easily reversible causes that may not require benzodiazepines. That being said, one of the most important point-of-care investigations to carry out would be a random blood glucose to check for hypoglycemia. If the patient is hypoglycemic, this can be easily reversed by the administration of IV 50% dextrose water. Other easily reversible causes include thiamine deficiency. This is managed by intravenous administration of 500 mg of thiamine 3 times daily for 2 to 3 days, then 250 mg intravenously daily for 3 to 5 days, or until improvement, followed by oral maintenance 100 mg daily. Eclampsia is reversed by the administration of magnesium sulfate. Opioid toxicity is managed by the administration of naloxone at 0.4 to 2 mg IV. And in cases of isoniazid toxicity, intravenous administration of 5 mg of vitamin B6 slowly is the best option of treatment. This should be repeated every 2 to 3 minutes if seizures persist. Now, what do we do if the patient continues to seize? The next step would be the administration of benzodiazepines. We can administer 0.1 mg per kg of IV lorazepam, or 0.1 mg per kg of IV midazolam, or 10 mg of IM midazolam. If seizure persists after the administration of benzodiazepines, administer IV levetiracetam at 60 mg per kg. This can be combined with a simultaneous propofol or midazolam infusion. Now, if the seizure persists despite the treatment approaches already employed, it is indicative of refractory status epilepticus. In this case, we have a number of viable options which we can employ for optimal outcome. First, we can continue propofol and midazolam infusion simultaneously. We can also commence IV ketamine in addition to the propofol and midazolam infusion. IV valproate or other anti-epileptic drugs can also be added following ketamine infusion if seizure still persists. Now, if the patient continues to seize, what's the next step? The next best steps would be to continue already established protocols. Commence administration of ketones, as direct supply of ketones to the brain helps in seizure suppression. And finally, it would be important to search for other likely causes by thorough investigations, which we would be looking at now. Important investigations include a non-contrast CT scan. This is important as it helps look out for abnormalities such as structural lesions, acute ischemic stroke, intracranial hemorrhage, tumors, epidural or subdural hematomas, and other possible intracranial causes. Next, it would be important to carry out a complete blood count. An elevation in white blood cell count would indicate the possibility of an ongoing infectious process such as encephalitis. A comprehensive metabolic panel should also be carried out, as this would help rule out conditions such as hepatic encephalopathy and uremic encephalopathy. In women of childbearing age, it is important to look out for beta-HCG to check for pregnancy and rule out possible eclampsia. A urine toxicology screen is also essential so as to rule out drug intoxication. A lumbar puncture is also carried out so as to collect cerebrospinal fluid for CSF analysis and culture to rule out conditions such as meningitis and encephalitis. Also, it is important to carry out an arterial blood gas analysis to rule out metabolic acidosis, which is an important seizure trigger. Other important investigations include a chest X-ray to rule out pneumonia and a 12-lead electrocardiogram. Finally, let's take a look at some important complications to look out for in a patient with status epilepticus. These include hypothermia, aspiration pneumonia, respiratory arrest, rhabdomyolysis, arrhythmias, and sudden death. And with that, I want to say a big thank you for watching this video. If you found it helpful, please consider giving it a thumbs up and subscribing to follow the channel and find out as more videos come out. See you in the next video. Bye for now.